When a chronically dizzy patient enters the clinic, they often describe a persistent, low-level unsteadiness and an intense sensitivity to their surroundings. Persistent postural perceptual dizziness, or PPPD, is a chronic functional vestibular disorder. It is defined by non-spinning vertigo and unsteadiness lasting 3 months or more, often worsening when the patient is upright or exposed to complex visual stimuli. Despite these severe symptoms, clinical imaging and vestibular tests often return structurally normal results. This includes caloric testing, which uses temperature changes in the ear canal to check for peripheral nerve weakness. The inner ear labyrinth, the hardware of the vestibular system, remains intact. The sensors responsible for detecting head movement and gravity are functioning as intended. The disconnect between accurate hardware signals and the patient's perceived instability suggests that the source of the dizziness lies in how the brain processes that information. PPPD involves a disorder of central sensory integration. In this state, the brain misinterprets environmental data and assigns incorrect weights to incoming signals, leading to a state of sensory mismatch. By mapping the neurobiology of this mismatch, we can trace how it generates the specific movement strategies physical therapists observe during an evaluation. Successful treatment relies on shifting focus from the search for peripheral damage toward the brain's integration algorithms. Healthy human postural control relies on the dynamic weighting of 3 distinct sensory streams, all feeding into a central processor in the brain. The visual stream provides spatial orientation based on optical flow, the pattern of apparent motion of objects in a visual scene. The somatosensory stream provides proprioceptive grounding, using feedbacks on the feet, ankles, and joints to determine the body's position relative to the surface. The vestibular stream serves as the internal gyroscope, confirming head acceleration and the direction of gravity. The central nervous system constantly shifts reliance between these streams. When walking in a dark room, the brain automatically reduces visual weighting and increases reliance on somatosensory and vestibular inputs. Maintaining balance requires this triad to remain fluid, allowing the brain to trust or discard specific sensory data as the environment changes. PPPD typically begins with a sudden acute event, such as a panic attack or benign paroxysmal positional vertigo, a condition where small calcium crystals in the inner ear shift out of place, causing brief but intense spinning. During this trigger event, the brain enters a protective state. It shifts weighting away from the unreliable vestibular system and relies heavily on visual and surface data to prevent a fall. In PPPD, the system fails to recalibrate after the threat has passed. Even when the vestibular signal returns to normal, the visual and somatosensory streams remain locked in a high-gain, hypersensitive state. This permanent high-gain sensitivity overwhelms the central processor with simultaneous maximum-strength signals. The processor must now manage conflicting data from multiple channels, creating the constant perception of sensory mismatch. The resulting dizziness represents the conscious experience of this data overload. The brain is saturated with high-gain protective signals that it no longer needs. This high-gain sensitivity dictates the specific behaviors and symptoms we see in the clinic. One primary manifestation is visual dependency, where the brain relies pathologically on optical flow because it has stopped trusting the vestibular signal. This often leads to the grocery store effect, where intense dizziness is triggered by complex, high-contrast environments filled with repetitive patterns. When a patient enters this environment, the visual stream surges. This flood of data overwhelms the central processor, leading to a localized failure in integration. This data overload produces immediate postural instability, as the brain incorrectly interprets the motion of surrounding patterns as the body's own movement. Visual avoidance functions as a logical behavioral adaptation to prevent this overwhelming influx of sensory data. The second clinical manifestation stems from the other hyperinflated node, the somatosensory stream. Surface dependency involves a sustained hyperfixation on physical grounding and joint feedback to determine the body's orientation. This manifests as a maladaptive strategy involving high-tone, stiffened movement. The kinematic model shows intense muscle co-contraction and the locking of the knees and ankles. By stiffening the limbs, the patient is attempting to generate more somatosensory data to feed a central processor that feels unanchored. While intended to increase stability, this defense mechanism eventually fails. Constant stiffness degrades the quality of natural proprioceptive feedback and prevents the micro-adjustments necessary for fluid, upright balance. The rigid posture and robotic gait characterizes a brain attempting to manufacture reliable spatial coordinates in the absence of a trusted vestibular signal. Standard vestibular rehabilitation exercises designed for acute injuries often fail with PPPD patients, sometimes making their symptoms worse. These traditional exercises focus on strengthening a vestibular organ that is already structurally sound, while the actual issue is the high-gain software error in the brain. The clinical target is desensitizing visual and surface dependencies. Habituation therapy uses graded exposure to reduce the gain on these overactive streams. By provoking a controlled mismatch, therapists force the brain to unlearn its threat response, eventually restoring the triad to a balanced, dynamic state. Rehabilitation also requires breaking down the patient's rigid movement patterns to teach the nervous system that fluid, low-tone motion is safe. We can now see the full progression. An initial trigger leads to a failed recalibration, creating a sensory mismatch that drives visual dependency and rigid physical adaptations. The patient's avoidance of complex environments and their stiffened gait are biological responses to a corrupted sensory weighting system. Resolving PPPD involves shifting intervention from the inner ear hardware toward retraining the brain's fundamental integration algorithms.